Here you go. We can talk about continue previous discussion and just with applicability more so to pediatrics, looking at PET MRI. So I'm going to talk about the utility of pediatric PET MRI. I'm going to discuss some of the potential applications using case scenarios in pediatric neuro-oncology, Hodgkin's lymphoma, non-Hodgkin's lymphoma, Ewing sarcoma, rhabdomyosarcoma. Going to maybe explore a little bit of potential application of PET and MRI in cerebrovascular disease assessment in children, with application to Moyamoya disease, and also look at maybe some use of PET MRI in musculoskeletal disease. So first, about the utility of PET MRI, as we've been discussing already, one of the advantages as expected would be the ability to co-register the PET images with the MRI images to get improved anatomic localization. Well, we expect that. And additionally, in pediatrics, though, the main driving force is the fact that patients would require less sedation if they were to get one procedure as opposed to going to a PET and an MR or a PET and a CT, combining it into one would mean that they'd spend less time being sedated or under general anesthesia, and also would reduce the duration of the acquisition time, the total acquisition time. And there's also a possibility of getting additional functional data through dynamic PET or contrast enhanced MR type functional information. Also, major driving force in pediatrics is reduced radiation exposure to children as they receive a PET scan and an MRI scan rather than a PET scan and a CT scan, which the CT containing ionizing radiation. Also, the MRI has the ability to better characterize potential soft tissue lesions, lesions in brain, spine, and bone marrow, for example. However, MRI does have a few of its own limitations. It's not great at characterizing cortical bone lesions. As we've heard already, there are limitations in terms of assessing lungs and mediastinum and lung nodules compared with CT. And the MR acquisition is longer than CT, which can be an issue in pediatrics, of course. And we've already talked about the issues of requiring, therefore, longer sedation and also longer general anesthesia time with MR in comparison with the CT scan. It's contraindicated in patients who have metallic implants. And also, the attenuation correction in MRI is more complicated and more prone to generation of artifacts, but also it's not as direct. CT is looking specifically based on determining attenuation of electromagnetic energy. That's what the modality is. Whereas the MR is, you can only kind of try to correlate it with that parameter in doing attenuation correction. So clinical situations where MRI may provide additional useful information would be in brain malignancies, seizures, and also body tumor imaging, where, for example, MSK tumors, pelvic tumors, liver tumors, lymphoma, and neuroblastoma. Now, we do have a PET MRI in London, Ontario that was installed in 2012, and we see here the installation. It was put in by crane, as is usually the case, and it's 9 tons, and so it's located in one of our hospitals, St. Joseph's Hospital in London, Ontario. It's currently used mostly in research protocols at this point in time. We have not been using it in pediatrics, though. So instead of showing actual current PET MRI cases, I'll be showing fusion cases and discussing the applicability toward pediatrics of PET MR. So, as we've already seen, there's been cases in pediatrics, just as in adult oncology, the brain imaging would be a major area of focus in pediatric for PET MRI. And here we have a case of a 7-year-old boy with recent resection of an anaplastic astrocytoma of the cerebellum. And we can see, let's see what we have here. So we can see that there's an area in the cerebellum with some contrast enhancement of abnormality with suspicion for whether or not there's actual disease recurrence versus inflammatory changes postoperatively. And the PET does show some increased activity in the medial aspect of the cerebellum. And this does correspond with what is likely recurrence of disease. And in this case, a patient with glioblastoma multiforme, again, there's an area of enhancement, an area of increased activity on the PET images, and corresponding with, in the corpus callosal region, increased activity suggestive of recurrence of, or suggestive of disease compatible with malignancy. Now, in Hodgkin's disease, there are applications that have been demonstrated in the past. So, 11-year-old boy with Hodgkin's disease, we see patients PET scan, or sorry, MRI scan, excuse me, with no significant abnormality, however, on the, just gonna go forward here. On the PET scan, there was an abnormality in the left upper quadrant region, and it was uncertain whether or not it corresponded with spleen or a small or a large bowel. In the PET MRI, it was seen that this did correlate with the spleen and not the large bowel, and so we've already heard of the usefulness or the utility of co-registration between the PET and the MR, and how that may have some diagnostic improved accuracy than just side-by-side imaging. They felt in this particular case that side-by-side analysis didn't really solve the problem. 13-year-old boy with Hodgkin's disease who has disease in the cervical region, in the supraclavicular region, and also in the right axillary region, and there's in the right pulmonary hilus. So that's fine, but there's also this focus here in the in the pelvis on the PET scan, which on MR at first on just side-by-side imaging was thought to represent activity in the ureteral bed. Let's see if this moves forward. Okay. So it's thought to be within the ureter, but then on fusion imaging, it was seen to correspond with an enhancing nodule, and this did upstage the patient, so they had parailiac lymph nodal disease, so now the patient went from having stage 2 disease to having stage 3 disease because of the PET MRI combination approach. 12-year-old girl with back pain. Here's a case where with non-Hodgkin's lymphoma, there was an area of enhancement on the MR that was thought to represent possibly inflammation or malignancy. They weren't sure, but they got the PET scan. The PET scan does show mediastinal disease and disease in bones, corresponding with the areas of enhancement on the MR. And so we have a situation where the MR is useful for imaging the spine, and also a situation where the PET was good for correlating those lesions. So we see in this sort of a scenario where PET MR had added value over that of PET CT. Would have had added value anyways. So now I thought I'd just discuss a little bit about perfusion MRI and perfusion PET potentially with application to cerebrovascular disease in children. So we could just explore a little bit of this approach perhaps that could be used in the future. Moyamoya disease is a chronic occlusive cerebrovascular disorder that involves, in which children develop occlusions, develop thrombuses and thrombi and occlusions of the cerebral vasculature, leading to TIAs and strokes. The reason it's called Moyamoya disease is it means puff of smoke, as we know in Japanese, and here's an example of the angiographic appearance of that puff of smoke appearance, which represents the collateral circulation in the disease entity. So MR is capable of being used in perfusion imaging of the brain, and in doing so there are two different approaches. There's one where you could do something called dynamic spin contrast enhanced MR, where we give contrast and then look to see what the perfusion of that contrast is in the brain and how that changes. Alternatively, we could do arterial spin labeling, where we label the patient's own blood without actually removing any of that blood before it enters into the brain parenchyma, for example. And in using these types of procedures, a certain sequence called T2 star weighted imaging is used, and what that does is it looks for abnormalities or inhomogeneities in the magnetic field as the contrast approaches, let's say, the brain parenchyma in this case. And the T2 star weighted image then shows, as the contrast approaches the brain parenchyma, there's a loss in signal over time, and this can be converted into a concentration time activity curve, such as this, where we see the concentration of the tracer contrast within the brain parenchyma. We can see that over time and how it varies. And from this, we can establish parameters such as time to peak of the contrast, mean transit time at the contrast, and cerebral blood volume, which are all important parameters in assessing patients with cerebrovascular disease, not just in pediatrics, but in adult cases. So in Moyamoya disease, here's an example of a patient who had a lesion in the centrum semiovale on the right side, and we see that there's leptomeningeal enhancement on T1-based contrast-enhanced MR, and we can see that there's the cerebral blood volume isn't particularly changed, but there's a reduction in or delay in mean transit time throughout the right cerebral hemisphere. And so these patients can undergo certain procedures, such where they take the temporal artery, for example, and actually anastomose it to the dura to increase perfusion. And this, you can see that there's changes in cerebral blood flow throughout the brain, but also the mean transit time, which is no longer as delayed on this set of images in the right hemisphere in total. And so this patient is, you can see at least some sort of a quantifiable indicator of improvement using these parameters post-operatively. Now, here's a patient who, you can see there's a bit of an enhancing lesion, a patient who's an 11-year-old girl with stroke or with an infarct, and we can see on the diffusion weighted images, we can see this area of increased signal within the right frontal region and representing an infarct, because there's basically where there is an infarct, there's increased edema, and the edema prevents the migration of contrast and water molecules. And what this does is it picks up on that reduced diffusion and can then create a higher, we see a higher signal. Cerebral blood volume has been reduced a little bit in this area. However, the transit time has increased substantially, as illustrated both on ASL and also illustrated on DSC type imaging. So F-FDG PET, though, also has applications for cerebral blood flow, as we know, and using two tracers such as CO2 and H2O with O15 labeled water, and using the Fick principle and Keddy-Schmidt equations, we can calculate the actual cerebral blood flow. And also the big advantage of PET is its ability to detect cerebral metabolic utilization of oxygen. So the oxygen ejection, or the oxygen extraction fraction can be determined by taking serial measurements of cerebral blood flow and by determining the cerebral metabolic rate of oxygen. And this, and also other parameters that we can derive from PET perfusion imaging are things such as the cerebral blood volume. We can also determine the cerebral perfusion pressure, which is the cerebral blood flow divided by the cerebral volume, and also its inverse, which is the mean transit time of RBCs through cerebral vessels. And this type of pathology has been demonstrated using PET in adults, but it also applies toward children. It applies even more so toward kids because they're they have more intact hemodynamic changes following stroke or insult to the brain, because their insults are perhaps less chronic than those of adults, frequently. So in this first stage, we see an increase in cerebral blood volume. The patients may be asymptomatic. However, in this stage of Moyamoya disease, where there are these little infarcts and collateral blood flow being formed, we start to see this metabolic reserve stage, where it's no longer hemodynamic changes, but changes in oxygen extraction fraction, where the oxygen extraction increasing over time. And then in this range here, the patients start to have strokes, as well as TIAs, and irreversible change starts to occur. Now, and this can be assessed using PET. Here's an example of patients who have, or non-symptomatic, who have a certain cerebral blood volume and certain oxygen extraction fraction, and then those who have TIA tend to have a higher cerebral blood volume, an increased oxygen extraction fraction, and then we see that those with both TIA and infarct tend to have a slight reduce, they're beginning to decompensate and have a reduction in blood volume, but also an increased oxygen extraction fraction. So this oxygen extraction fraction is a great parameter for assessing those who might benefit from an interventional revascularization. And here's an example of a patient who has a T2 weighted MRI image showing no significant lesion. I'm just going to go back. However, the mean transit time is increased throughout the whole of the left cerebral region, suggesting that there's collateral flow with reduced rate of blood flow. And this is assessed through diffusion-weighted MR. And then on the PET images, we can see an increased oxygen extraction fraction. And with the combination of these two results, we have perhaps pre-selected a patient who shows no obvious imaging signs of stroke on the anatomic images, though on the functional images may benefit from surgical intervention based on combined MRI functional images and PET functional images. So just going to go back now to some MSK scenarios, a couple of them. So here's a situation where the patient with Ewing sarcoma with proven METs proximally, who had in the femora bilaterally on MR, but on PET images shows no significant abnormality. So this is a situation where there's a false negative PET. So what can cause a false negative PET? Well, in this case, probably altered or low glucose metabolism, or its inability to take up the tracer, in this case. METs with small size can do so. What about MRI? Well, small lymph nodes and bone METs. Small lymph nodes can do them, and small bone METs might be arise with or might generate a false negative MRI. Lesions near the bowel might be difficult to assess as well. False positive PETs, well, the trick of interpreting PET is oftentimes trying to figure out what's normal, what's physiologic and what isn't. So brown fat, physiologic muscle uptake in bowel, ureter, ovary, inflammatory changes, or normal bone marrow following chemotherapy, for example, might be false positives. What about with MR? Well, post-therapy changes are always the issue. Is it post-therapy or is it recurrence of disease, for example? And also, just as in CT, there's concern for, is that enlarged lymph node truly malignant, or is it just inflammatory? Here's a situation with a patient who has rhabdomyosarcoma. We can see the lesion on PET and central necrosis in the photopedic region, and it's well delineated here with the contrast surrounding it on MR, and presumably the definition of the MR of the tumor would be able to help aid in surgical resection. Patient, again with rhabdomyosarcoma, there's uptake in the oral region because the patient had a pacifier, so that was just not significant. However, there was uptake in the tumor mass in the right abdomen. And then on MR, we have a good definition of where the uptake is in the tumor in PET. And this would presumably aid, of course, in both surgical, if the surgeons had access to these images, and perhaps, and also the in radiotherapy planning potentially, if they knew what areas of the tumor were FDG avid. And here's another case of a patient with a Ewing sarcoma with uptake on the bone scan, or activity on the bone scan in the right ilium. And we can see activity in on the FDG PET scan in the tumor mass, which is greater than that implicated by the bone scan. And we can see on the combined MR FDG images here, the anatomical outline of where the FDG uptake is, and would have, again, a good description of where the lesion would be for surgeons potentially. So here's an application that was discussed in the literature. I don't know how realistically applicable it really is, but there are patients who have osteomyelitis, for example. We could consider doing PET-CT. We wouldn't want to do them in all patients presenting with osteomyelitis because of the radiation burden. But what they saw in this particular group saw that in patients with recurrent osteomyelitis that was not well characterized on MR for being positive or negative might benefit from having a PET scan done. And in this case, here's the disease identified originally on the MR images in the left distal tibia. And then following antibiotic therapy, there was, again, this sort of area of abnormality, contrast enhancement on the MR, and they wanted to determine whether or not it represented truly osteomyelitis, and the patient did undergo a PET scan with some increased activity in the left distal tibia, and then we see here on the PET-CT that there was increased activity corresponding with the same area of abnormality on the PET-MR, on the MR, and presumably had this patient underwent PET-MR, they would have been saved an extra exam, or and also it would have correlated well with the MR pathology immediately. So, but anyways, going on to conclusions as to whether or not the utility of PET-MR in pediatrics. Well, we do know that there is some use in terms of better disease definition through accurate co-registration. Is that really what's going to drive this? I mean, you do have a PET scan, PET-CT, let's say, and you do have an MR scan. Do you really have to confuse them? Well, or do you really have to fuse them, excuse me? It's likely that, as we know, the real driving force isn't that so much. That might become even more of a driving force in the future, but really it's because of the reduced number of procedures. So instead of undergoing a PET-CT and then an MRI, and having to sedate for both procedures, you're able to just have a PET MRI and only sedate for one. However, the MRI does take a longer time, and but there is less overall radiation associated with the PET MRI than with the PET CT. So that's another driving force in pediatrics. So potentially conditions where we already know that we have to get an MRI and a PET examination in a patient, those would be situations where it would be better just to fuse it and have a PET MRI. So those are the applications potentially where we'll see more use in pediatrics in the future, or where the loss in CT resolution isn't so great that an MR would be actually useful, or in situations where we know that the involvement of the disease might involve structures that the MRI is better capable of assessing. So these would be areas of potentially in the future where we'll see more involvement of PET MRI in pediatrics than we conceivably would see it. Well, thank you very much.